Good morning. Our topic for discussion today is on provisional restorations. These are the contents. Moving on to the introduction. So, interim crowns, it is another name for provisional crowns. Okay, interim crowns or interim partial fixed dental prostheses are essential in a prosthodontic therapy. So, usually after a tooth preparation, a temporary crown is given for multiple reasons, right? So, in certain cases, when we do a full mouth rehabilitation, also temporary crowns are often given so as to ensure that there is no problem with the vertical dimension with the aesthetics and so on. So, provisional restorations and a fixed partial denture is always very essential. So, according to GPT-9, the definition is it is a fixed or a removable dental processes or a maxillofacial processes designed to enhance the aesthetics, stabilization, and or the function for a limited period of time, after which it is to be replaced by a definitive dental or maxillofacial process. Often, such prostheses are used to assist in the determination of the therapeutic effectiveness of a specific treatment plan or the form and function of the planned treatment for definitive processes. So, the basic requirements for a provisional restoration are divided under three headings. They are the biological, mechanical, and the aesthetic. So, biological is given under multiple headings. In the biological aspect, what we have to consider is it should be able to protect the pulp. That is, the provisional crowns or the provisional restoration should be able to protect the pulp. It should be able to maintain a good periodontal health. It should provide a good occlusal compatibility. It should be able to maintain the position of the tooth, and it should protect the tooth from fracture. Mechanical aspect is it should be able to resist the functional load. It should be able to prevent displacement, and also it should be helpful for removal after reuse. Removal after reuse meaning, so once we cement a provisional crown, if by any chance we have to remove it, we should be in a position to remove it and re-cement it again. So there should be sufficient strength for that. And the third aspect is the aesthetics. The provisional restoration should be easily contourable, it should be color compatible, it should be translucent and color stable. So just to have a glimpse of each property in details, in the biological aspect, to protect the pulp. When we do a tooth preparation, for example, if you're doing a vital tooth preparation, there are high chances that the patient can have sensitivity. So if a provisional crown is given or a provisional restoration is given, it must be in a position to seal and insulate that prepared tooth so that sensitivity can be prevented and there can be less irritation to the pulp. So in certain cases, if there is any marginal discrepancy, there can be a marginal leakage and then it can result in irreversible pulpitis. Right. Then the second factor is to maintain the periodontal health. So as you can see in the figure, if for example your prosthesis is a little sharp or so, it can cause inflammation or any hemorrhagic tissue if present. Okay, it may be very difficult. It may be very difficult for completing the treatment. So then the occlusal compatibility and the tooth position. So if you do not give after a tooth preparation, if you do not give a provisional restoration, what is going to happen is after a few days the tooth might supraerupt or the tooth might move mesially or distally. So after tooth preparation, to avoid tooth movement, we have to give a provisional restoration. Another situation is prevention of the enamel fracture. So we also know that once a tooth preparation is already done, the tooth structure is very weak. So a provisional restoration, we should be in a position to protect or strengthen a weakened tooth which is there after preparation. So the aesthetic aspect is it should be easily contourable, meaning it should be easily shaped. It should be color compatible. It should be slightly translucent to get good aesthetics, and it should be color stable. It should last for a period of time. So these aesthetic principles are actually required when we're giving a temporary process or when we're giving a provisional restoration for a longer period of time. Now the rationale. So the basic idea as to why we have to give a provisional restoration. There are a few points. One is it should protect the pulp and sedate the prepared abutments. we will be in a position to evaluate the parallelism of the abutment, specifically in fixed partial dentures. Then immediately replace the missing tooth. It can immediately replace the missing tooth if you give a provisional restoration, and it will prevent the migration of the abutments. It will definitely improve the aesthetics. It can provide an environment conducive to periodontal health. It will help to evaluate and reinforce the patient's oral home care. Then it is also used for stabilizing a periodontally weak tooth. So we can use this temporary process as a tool for splinting. Okay, and anchor the orthodontic brackets during minor tooth movement. So these are done in young patients where a root canal treatment is done and the tooth is fractured, so a crown has to be given before the orthodontic treatment. So instead of giving in the anterior regions, instead of giving a metal crown, what we can do is we can give a long-term provisional acrylic crowns with onto which orthodontic brackets can be attached or bonded. It will help in developing and evaluating the occlusal scheme before a final process is made. It will also allow evaluation of vertical dimension, phonetics, and masticatory function, specifically in a full mouth rehabilitation case. It will help to determine the prognosis of questionable abutments in the overall restorative treatment plan. So, in certain cases where the tooth is periodontally compromised, a provisional restoration, a long term, can be given to check the status of the tooth. So what are the ideal properties that we require for a provisional restoration? The first one is the adequate strength and wear resistance. It should be biocompatible. It should have a low exothermicity. It should be non-porous and dimensionally stable. It should be comfortable for the patient. Aesthetically acceptable shades should be there. It should be color stable. Adequate working and setting time. It should be easy to remove and re-cement by the dentist. It should be conducive to routine oral home care and cleaning procedures. Finishes to a highly polished plaque and stain resistant surface, and should be relatively inexpensive. So now moving on to the classification. So provisional restorations are classified under major 4 headings. First one is based on the method of fabrication. They are classified as preformed and custom made. Then they are classified under the heading of material used, that can be resins or metals. Then based on the duration of use, they are short term and long term. Based on the technique of fabrication, they are direct technique, indirect technique, and indirect direct techniques. So we'll just go into the materials and methods of fabrication. So under the heading classification, provisional restorations, I told you, are classified into 2: prefabricated and custom made. So as the term suggests, prefabricated, we can already understand that the shape of the tooth, the size of the tooth is already readily available with us in the form of shells. Custom fabricated means according to the patient's measurements, we have to fabricate a new crown. So what are actually preformed crowns is the anatomic shape. According to the anatomic shape, the stock materials or stock crowns are available. Their advantage is they help us save a lot of time. So in this custom made, we have polycarbonate crowns. As you can see in the figure, these are the crowns that are available as sets of different sizes. They are usually available for incisors, canines, and premolars. The other type of preformed ones are cellulose acetate strips. So what happens is these are small shells, transparent shells of just of measurement or thickness of just 0.2 to 0.3 mm. And these are very transparent materials, so you have to choose the shape of the tooth and then accordingly add a resin material to make it into the shape. Then polishing and trimming can be done. So then metals are available. 2 types of crowns are available in metals. One is the aluminum and tin silver, and the other one is nickel chromium. As you can see, according to different shapes based on the different quadrants, they are already available as preformed. Right, we just have to contour it accordingly and crimp it to cement. Now classification, as we discussed earlier, based on the materials used, it is custom made materials are classified into 2 types, that is the resins and metals. In resins we can have acrylics or bisacrylic. Metals, it is casted metals. Right. So now based on the duration of use, they are classified under 2 headings: short term and long term. So what do you mean by short term? Any processes that is given for up to 2 weeks is a short term process. They are used when the process is used just for a maximum period of 2 weeks. They are indicated after tooth preparation in a fixed partial dentures. So they are either custom made resin or available as free-formed crowns. So polycarbonate or aluminum crowns are the most commonly used short-term provisional restorations. So now long-term meaning long-term when a provisional process is used for more than 2 weeks, it is called a long-term. So it is indicated when there is a long span posterior FPD, patients undergoing implant therapy, extensive periodontal treatment, orthodontic stabilization, and when there is a requirement for the evaluation of change in vertical dimension. So basically for a full mouth rehabilitation case wherein we increase the vertical dimension, we do a mock-up and we have to check for the aesthetics, the occlusal loads, the force, the phonetics. In such cases a long-term provision can be given, or in also cases where we have to do a full mouth rehabilitation with a periodontal surgery. In such cases for soft tissue healing also this long-term provisionals can be given. Now classification based on the technique, as we have already seen earlier, is divided into three: direct technique, indirect technique, and direct technique. Very easy to understand. When we say it is a direct technique, it is just to we just have to understand that it is fabricated in the patient's mouth. So if it is an indirect technique, the thing that we have to understand is it is fabricated outside the patient's mouth. So now indirect and a direct technique, we are in a position to understand that both the techniques, that is initially an indirect technique is used and later on a direct technique is used. So just to give you an example of a direct technique, alright, if you can see the figure, in the first figure you can see a tooth that is missing. Okay, the tooth that is missing is replaced with an acrylic tooth with a wax in the patient's mouth. An impression is taken, or rather an index is taken with a putty material or an alginate material. Once this is taken, you do a tooth preparation in the patient's mouth, and just saving the impression or the putty index taken earlier, we can just add a bisacrylic material into the index and then place it in the patient's mouth. And once the material sets, you can remove the index and you can see that tooth there. So this is the direct technique. So now indirect technique, as I earlier told you, it is outside the patient, it's done outside the patient's mouth. So similarly, when a tooth is missing, a cast is taken. In the cast, an acrylic tooth is placed, and then once that is placed, a putty index or an alginate index is taken on the cast and it is left outside. Then intraoral preparation is done, and then using this index which was taken on the cast, a provisional restoration is made. Now what is the difference between indirect direct technique to the other two techniques? In this technique, one procedure is done outside the patient's mouth, and then the second one is done in the patient's mouth. So here what we do is, we take a cast of the patient, we use an acrylic round, we take an index. So that is similar to your indirect technique or done outside the patient's mouth. Once the index is received, now what we do is we do a tooth preparation on the cast itself. And then on that cast we make the provisional restorations, that is taken and kept. Now the preparation that we have done on the cast is entirely different to what we are going to be doing on the patient's mouth. So after this is done, a temporary provisional is already 3 unit FPD in this picture is already available based on the preparation done in the cast. Now what we do is we do the preparation in the patient's mouth. Once this preparation is done, there is definitely going to be a space between the prepared tooth and the provisional restoration that we already fabricated. So then additional material is added onto the already made provisional restoration and is placed in the patient's mouth and wait for it to set. Once that is done, it can be trimmed, polished and cemented. That is why it is an indirect direct technique. So now procedures, just to give you an idea. So polycarbonate crowns, if you can see, the before tooth preparation, the width of the tooth is chosen. The shape of the tooth is chosen, the size of the size of the tooth is chosen. Okay, after that, from the available shells that we have, we choose a one which is almost similar. Then we do a preparation. Once the preparation is done, again additional acrylic material is added into the polycarbonate crown and it is placed in the patient's mouth to set. Once it sets, we take it out, trim it, contour it, polish it and cement it. That is how polycarbonate crowns are done. Now you can see a cellulose acetate. As I earlier told you, it is a preformed crown. It is available as thin strips of 0.2 to 0.3 mm. So here you can see a peg lateral. In the peg lateral, what we do is we correct these acetate sheets and we place it exactly there. Once that is done, a composite material or an acrylic material can be placed into the sleeve and placed back into the patient's mouth. Once it sets, you can just tear it off or cut it out and then polish it. So anatomic metal crowns, as you can see, stock crowns are available. These are just contoured onto a stand and they are crimped and they are cut. If excess is required, if excess has to be cut, they are cut and then placed in the patient's mouth. Now the limitations of our provisional restorations, of course, all comes with positives and negatives. So limitations of a provisional restoration is lack of adequate strength. So it shouldn't fracture, or it shouldn't fracture, but the actual problem is provisional restorations are comparatively weak, so they fracture. So inadequate marginal adaptation, they do not have proper marginal adaptations most of the times. Then it has a poor aesthetics. Plaque accumulation is always possible. Compromised bonding characteristics and mild to moderate tissue irritation. So as of clinical practices, the lack of adequate strength, inadequate marginal adaptation, poor aesthetics, plaque accumulation is very commonly seen. So now, since we have learned about provisional restorations, we should also understand as to how to cement these provisional restorations, right? So the ideal requirements of a temporary luting cement is it should be able to seal against the leakage of oral fluids. It should strengthen the consistent with intentional removal. Low solubility. It should have a blandness or obtudency. Chemical compatibility with the provisional polymers and convenience of dispensing and mixing, ease of eliminating excess, adequate working time and short setting time, and compatibility with the definitive luting cements. So the temporary cements are classified under three headings: the calcium hydroxide, the eugenol cements and the non-eugenol cements. So in nowadays practice, what we usually use is to give a chair side temporary crown is the bis acrylics. So the bis acrylics always we use a non-eugenol cements. The reason for using a non-eugenol cements for a bis acrylic crown is if the non-eugenol cements are not used, the eugenol present in the eugenol cement will inhibit the setting reaction of the bis acrylics. So non-eugenol cements are most commonly used. So now, just to have a glimpse or for giving you an idea as to how far provisional restoration in the studies have come in the field of provisional restorations, or innovations have come into the field of provisional restorations. So CAD/CAM based long-term provisional materials. So as we know, we have heard of blocks and blanks. For Emax crowns, for permanent restorations, we have heard about Emax crowns or zirconia crowns, right? So similarly, for acrylic or for short-term or long-term temporary crowns, blocks or blanks have been introduced, right? So they are available in all the shades. These are easily can be given for a long-term provisional restoration. So some of the brands are the TelioCAD, VitaCAD, Zircon based PMMA blocks. These are the blocks that you can see. So the other one is the rapid prototyping. Rapid prototyping means 3D printed. So these are the resins that are available which can be easily 3D printed for a temporary crowns. So the example is the NextDent for Ceramil crown and bridge. So another one is Integrity Temp. These are long-term temporary materials that has a barium boron aluminosilicate glass to give it a fluorescence, so to give it a natural look when light appears. So this is necessary to avoid the black appearance exhibited by traditional materials in the presence of UV lights. Another one is the rubberized urethane. This material is again fluorescent. It is strong, it has high impact resistance, and is a provisional product that does not shrink or distort and grips the tooth tightly. So it is virtually eliminates the fractures and debonding due to its rubberized urethane chemistry. So the example is the Tuftem from Coltine, I suppose. and the other one is a flexible cast for interim restoration fabrications. So here a glue gun can be used. Once you take a putty light body impression, a glue gun can be used for making a provisional crown. So this glue gun is injected into the impression. Once it sets, you can take it out. In the second figure, as you can see, you will get a flexible type, a glue type, a flexible type of an cast. On that cast, you can easily fabricate a provisional, and you can easily remove it from that glued position, and then that can be trimmed, polished, and placed. So another type, or a modified, or the recent advanced, is a ProTemp. ProTemp is usually a 3M brand material. So those are usually available as space system which can be injected from a gun. Here in ProTemp has also come out something called a back resin preformed crown, wherein crowns are already available. The thing that we have to do is we have to contour the margins, we have to place it in the patient's mouth, ask the patient to bite, adjust the occlusion and contour the tooth. Once that is done, light curing has to be done intraorally, and once the external surface light cured, we have to take it out and do the light cure intraorally also. Once that is done, if required, we can trim, polish it, cement it using eugenol free cement. Using a floss, we can clean and polish. So coming to the conclusion, the quality restorative dentistry needs quality provisional restorations for predictable results. Dentists therefore need to be familiar with the range of materials and techniques for the short-term and long-term provisionalization. Forethinking and planning are also needed to ensure that most of the appropriate provisional materials are used, especially when multiple teeth are to be prepared or where occlusal or aesthetic changes are needed. Thank you.